Medicating Normal was being made, and the content of it really resonated with my experience and that of a lot of other people that I know. So tonight, the reason that we have showed you Medicating Normal is to provoke discussion around the use of psychiatric medication, and to also discuss how we treat mental illness in our society. The UK has seen a massive rise in the prescription of antidepressants during COVID, especially to women and to young people and teenagers. So I have an expert panel with me tonight to discuss these issues. So tonight I am joined by Dr. David Healy. He's a professor, researcher and author of Pharmageddon, and he is an expert witness on the harm caused by psychiatric drugs. He's also the founder of risk.org, which is a website that gives consumers accurate information about the medication that they are taking. And then we have Stevie Lewis, and she is a survivor of antidepressant dependence and withdrawal. She is the co-author of The Patient Voice, and she is a campaigner in Wales. Miranda Levy is a national newspaper journalist who specialises in health and particularly mental health, and her new book, The Insomnia Diaries, How I Learned to Sleep Again, is published in June. And finally, we have Mark Horowitz, who is a training psychiatrist and a researcher with a PhD from King's College in the neurobiology of depression and the use of antidepressants. And he is currently conducting the RADAR trial, which is for people with schizophrenia, reducing their dose of antipsychotic medication. So, welcome. So while the panelists are answering the first question that I'm going to answer them, would people in the queue, would people in the audience like to put their questions or comments into the Q&A boxes, so then I can feed them in and start giving them to the panel? That would be great. Thank you very much. And I just want to set the scene by saying that 1 in 5 people in the UK are prescribed an antidepressant, and that's 6 million prescriptions, and that 25% of adults in the UK are taking drugs that can cause dependence. So, Miranda Levy, how did you find the film? Did you identify with any of the characters and their stories?
Yeah, well, like you, I found it incredibly powerful, and I identified with bits of all the stories, but there was specifically, well, there were elements of all of them, but probably the most with Shalimar, who's the waitress who's been on and trying to come off lorazepam.
And was that to do with her with her scales and chopping down the drug?
Well, that was an image that stayed with me, but there were so many things in common. So insomnia was my problem. I was prescribed benzos very early on in the proceedings, and first temazepam and then clonazepam, which I think is Klonopin in America.
Mm-hmm.
And that became the problem. As one of the other people said, the drugs became the problem.
Mm-hmm. And so, with the withdrawal, was that a protracted process? Are you still on medication, or?
You could argue that I'm not on clonazepam anymore, but I had a terrible, I mean, it's a long story, but I had a terrible experience where I went to rehab and was put on the 12-step program and was withdrawn far too quickly after 4.5, 5 years on them, and all hell broke loose, and which I compounded by coming off the rest of them myself, which I lost everything really the 4 or 5 years after, well, before it started. I'm not on those anymore, but I'm still on a couple of other pills. I'm on an antidepressant. I'm on Zopiclone, and I'm trying very hard to come off pregabalin, which is a bloody nightmare.
And I think that's called Lyrica in America.
Mm.
And that's also prescribed for nerve pain.
Yeah.
and anxiety and sleep as well. Is that right?
It's originally an anti-epileptic, I think. The doctors will confirm.
Hmm. Hmm.
Mm.
Okay. Mark, so you co-authored the Cochrane Review. Could you explain what the Cochrane Review is and the recommendations that were made?
Sure. So, thanks very much for having me here. The Cochrane Review, it was actually started by a Belgian GP called Ellen van Leeuwen, and she found that when she was seeing patients in her practice, she had a lot of trouble helping people to come off their antidepressants, and she was very surprised to find that the Cochrane collaboration had never conducted a study of how to come off these drugs safely. And as people might know, the Cochrane is probably the global leader in evidence-based science. They do reviews of everything, and the whole idea is for them to be independent of any drug company influence. So they're a very well-respected group. So she set about doing a review that I became involved with. She did 3 years of work for it, so it's really her review. What they found was that although there's a huge number of studies on starting antidepressants, there's at least 500, and there's probably 1,000 studies. They only found that there was 33 studies on how to come off antidepressants, which is in itself quite shocking how much attention is being paid to starting these drugs and how little there has been to stopping them. Even those 33 studies were very unhelpful. They mostly looked at relapse as an outcome, not withdrawal, or not how to stop the drug successfully. 13 of them stopped antidepressants abruptly. That means in 1 day. And most of the rest of them stopped them in just a few days or less than 4 weeks. In other words, they didn't, even the NICE guidelines, which is itself quite out of date, the guidelines in the UK, say that you should stop antidepressants over more than 4 weeks. So none of these studies had done that. Very few, only one of them had looked at withdrawal effects. And so the conclusion of the review was there is very little out there to guide clinicians or researchers on what is the best way to stop these drugs. And there's been very little interest in the topic. The major issue that the review points out is the problem with looking at relapse when people are stopped from their antidepressants. Because withdrawal effects, which we now know are fairly common, look a lot like relapse. When you stop an antidepressant, you can get low mood, become anxious, have trouble sleeping, changes to your appetite. And if researchers are looking only at relapse, where they give out questionnaires about depression, do you have trouble sleeping? Do you have trouble with mood? Then withdrawal effects can look like relapse when you measure them like that. And so the conclusion was the major confounder, the major confusing aspect of these studies was that withdrawal effects look like relapse. At the risk of going on for just a bit too long, I'll say one more thing, which is, although the review was not aimed at looking at should we continue antidepressants, it brought out a very important point, that the evidence that we currently use to recommend long-term antidepressant treatment is based on these trials where people are stopped from antidepressants. And in these trials, exactly the same issues come about as the ones in the Cochrane Review. When you stop antidepressants, people seem to get worse, but it's not clear whether that's because of withdrawal symptoms or because of relapse of the underlying condition. And none of the studies look carefully at withdrawal symptoms as a cause for this. And that means that the NICE guidelines, the current guidelines we use in the UK and around the world, that suggest that we should use antidepressants long-term are very flawed. And the evidence, there may not be any evidence that's robust that suggests we should be using antidepressants long-term. So the conclusion of the Cochrane Review was, one, researchers should pay more attention to this issue of how to stop antidepressants safely. Clinicians should be very aware of withdrawal effects when they stop people on antidepressants. And we need to rethink the evidence that we have the long-term use of antidepressants.
Just thinking, if a patient goes to their GP and says, I'm feeling weepy or I'm feeling stressed, and a lot of people have felt stressed in the last year, they may be put on an SSRI drug, and they wouldn't necessarily know that what they were experiencing was side effects or withdrawal effects. So, I mean, why isn't this information out there? I mean, why don't GPs know? Why don't we know?
We're trying. We're trying to get it out there.
Oh, hard. We are trying. Absolutely.
It's like the patient doesn't really have like an informed, information to make that decision to take the drug in the first place, maybe.
So
Anyway, because I'm going to bring David in here. Sorry, Mark. David, you were the first person in this country to flag up the problems with SSRIs, and I think I'm right in saying that you're one of the leading world experts on these types of drugs. So I want to ask you what you think the impact is of the rise of prescriptions for antidepressants during COVID to women and young people and teenagers. Do you think we're looking at like a public health time bomb?
Yes, I do. And I think one of the key things that came across from the program to me was how we've moved over the last 30 years since we had these drugs from treating what looked more like an illness to talking about the mental health problems people have. And if you listen closely to the things that get said, and particularly now during this period when we have COVID, mental health seems to be if I'm having a negative emotion of any sort, then I've got a mental health problem. And the idea of trying to take a pill, which is a bit like alcohol or whatever, I mean, we wouldn't think it's a good idea to start drinking just because you're feeling bored or angry or confused or whatever. And these drugs are available on prescription only because we figured they're more dangerous than alcohol. I mean, we've got alcohol available over the counter. These things are not available over the counter because we have every reason to think they're going to be more dangerous than alcohol. So one of the oddities we've got into is if people have a negative emotion of any sort, we've begun to think that we should reach for a pill. And that's awfully convenient for a lot of people who don't particularly want us to think, well, what's wrong with society? Do we need to reorganize society to make it work better generally for all of us? So let me take you back a little bit. And 28 or 30 years ago or so, when these drugs were coming on the market, when Pfizer launched sertraline, that's Zoloft elsewhere in the world, I was chairing the symposium that helped launch it. I was working closely with most of the companies that made these drugs and brought them on the market. And at the symposium, I gave a talk which said, look, serotonin is one of the most primitive neurotransmitters there is. We've got this new group of drugs that's going to be acting on it. No one really knows what they're going to do, and we should be keeping a close eye on what happens. Now, the very last thing we've done over the last 30 years is to keep a close eye on what happens. When you take these drugs, within 30 minutes of your first pill, you'll be genitally numb. But the label of these drugs doesn't mention that. For a load of people, their ability to make love gets wiped out by the drugs. For a bunch of people, the problems, their ability to make love, their genital numbness and things like that, persists for decades after you halt. And it turns out that the first report that this could happen comes from 1987. Now, why is that important? Well, that's 3 years before any SSRI was brought onto the UK market. So the companies knew things like this could happen, knew it before the drugs actually got marketed. They knew we could get hooked to these drugs and the problems could endure afterwards. Within 3 years of paroxetine being brought on the UK market, there were more reports of people being hooked to it than there had been in 20 years of all benzodiazepines combined. So Somehow we seem to have had the ability to ignore the fact that our sex lives are being wiped out, that we're getting hooked to these drugs. And the primary reason why close to 1 in 5 people here in the UK are on these drugs now is not because more and more people are being put on them so much as when you get put on them, people can't get off them. So the figure builds up the whole time. And there's no reason why it's not going to continue to build unless we can really find a way to treat the problems when you get on them and work out a way to change the culture so that when people are feeling bored or confused or angry or maybe unhappy, that they don't think, well, the answer to all this has to be a pill, because the answer really isn't a pill. One of the other things that I found out through working closely with the industry, and this plays a part in how things have gone, is that most of the academic literature on these drugs, pretty well all of it, whether it appears in the BMJ or the Lancet or the New England Journal of Medicine or wherever, is ghost written. Now, what do I mean by that? Well, I mean that there's distinguished professors who work in the Maudsley or work in Oxford or Cambridge or Harvard or Yale, whose names are on the authorship lines of these papers, and they haven't written the paper. They haven't seen the data. They haven't met the patients who are put on the drugs in these trials. And the NICE guidelines are based on a ghost-written literature, which says these drugs work wonderfully well and are free of problems. The articles that we see don't actually mention you can get hooked to these drugs, or you may become suicidal, or you may become alcoholic on these drugs. This isn't there. There's no access to the clinical trial data. If I've even been involved in a clinical trial for one of the pharmaceutical companies and want to get the raw data behind the trial, I can't. The apparent authors on the authorship line of the articles which say what this drug did in this clinical trial, they don't have and have never seen the raw data. So we've got an extraordinary picture where the companies are free to put into the best journals fake news. They can say the drugs work wonderfully well and are free of problems, which leaves me years later saying, Donald Trump was wrong. The greatest concentration of fake news on earth centers on the drugs your doctor gives you. And it's not just the SSRIs, and it's not just mental health drugs, it's all drugs. The problem, though, I think, is that the SSRIs, the antidepressants, are probably one of the most critical drugs of all, because as I've said, these are drugs which really don't do much good and cause awfully serious problems, from your inability to make love, from breakups of people's relationships, from the disinhibition they cause, and a whole range of other things that leaves us with, I think, a pretty grim picture, and it's not easy, not obvious how we're going to solve it. One of the perhaps problems from the Medicating normal picture that I picked out was I think all of the characters in it were great. I think they were all awfully brave and inspiring. But the picture to some extent says, look, these are issues we can solve if people just have a bit of willpower and get down to it and things like that. Well, I think we don't, even with the best willpower in the world, people don't always recover from these pills. There can be enduring problems that are left afterwards, and these things are only going to get worse if we don't get to grips with the whole thing. And I think we're a long way off from having got to grips with it as things are now at the moment.
Thank you, David. I'm sure there'll be a few questions and comments from the audience after that. But I want to bring in Stevie now. Stevie, did you identify with the stories in the film?
Well, most definitely. And David set the scene beautifully for how I come to be standing here, really. I mean, with all those characters, with all those people and the struggles that they had with withdrawal, that was a major thing where I identified with them. But talking about one of them specifically, I happened to pick out the same woman that Miranda did, actually, and that's because
Shalimar.
Shalimar, that's right. She just took the one drug as far as I could see, that she was on the benzo, whereas the rest of the people involved ended up polydrugged. But I pick on Shalimar. Hers was a benzo as opposed to mine was an SSRI antidepressant. She didn't seem to have particularly side effects from being given the drug for insomnia, as indeed I was given a drug for insomnia. But mine was paroxetine, which was mentioned earlier, which is Seroxat in the UK, Paxil in the States, or Arapax, I believe it's called elsewhere. I didn't have much in the way of side effects while I was taking it. Once I lowered the dose, because the therapeutic dose of 20 milligrams was a bit like a chemical kosh for a small woman, but I worked out I could take a lower dose and it was fine. But the issue for me, I think like Shalimar, was when I tried to stop. And her example, like mine, is a real interesting means of showing what can be done to the human body by just taking one of these drugs, never mind a handful, which is how so many people end up on. Yeah, you just put one chemical in there for a long period of time, and mine was 17 years, because it took me years and years of trying and failing to stop. And the body kind of accommodates these drugs. The drug tucks its way in there and your body cuddles it and takes it in, and it makes internal changes that you don't even realize are happening to you. The GABA receptors, the serotonin receptors, and then you stop, and as Miranda said, all hell breaks loose.
I'm just thinking, of the young people who are being prescribed these drugs and how it affects their, their growing brains, and like as David spoke about, the numbing and how that kind of relates to their growing sexuality and their experience in the world. It's quite a big thing. But I'm going to ask you also about the campaigning that you've done.
Yes. Well, yeah, I became eventually, once I got off this stuff, pretty angry, and I wanted to become involved in trying to do something, because it became apparent that here we were in, well, it was 2017, 2018, when I was raising my head above the parapet and finding that people were still being told the same story that I was, which is, you have a chemical imbalance in your brain. Here we are, off you go with a prescription, just take that, there's a good little girl. And I just couldn't believe that this was still happening, because this is what happened to me in December 1996. Same story, same narrative, which has become just part of our society now. So many people believe that depression or anxiety or insomnia, it's insomnia, my hormones, for goodness sake, that was apparently the cause of my chemical imbalance.
It's like insulin for diabetes thing, isn't it?
Oh yes, I heard that one. Yeah, absolutely. So I found the same story was being told, and I raised, with some encouragement from a fellow campaigner, Marion Brown in Scotland, I raised a petition in Wales, because I live in South Wales, to bring this to the attention of the Welsh Government through the public petition. And these two petitions, the committees asked for people to write in with their stories to back up what Marion was saying in Scotland and I was saying here in Wales. And Scotland particularly got deluged with stories. And we were approached by Dr. Angai from the All-Party Parliamentary Group for Prescribed Drug Dependence, because the All-Party Parliamentary Group had managed to persuade Public Health England to do a review to look at this problem of prescribed drug dependence in the UK. And these stories were brought together into a report which made part of this evidential review, and was a very important part of it. It transpired because the Public Health England said they didn't want to hear from individual people. They wanted to do this evidence-based review, but they didn't want people knocking up at the door, and going, hey, how about me? And our report, plus another one done by Roehampton University, I think, were the two vital reports which really added weight to the disturbing statistics that Public Health England found about the extent of prescribed drug dependence in England. So, as you quoted, 25% of adults in England are taking the dependence-forming drug.
And which are they, Stevie? Are they the Z drugs?
Yeah, you've got the Z drugs, the opioids, the gabapentinoids, benzos, and antidepressants.
Right.
Those are the 5 classes. Yeah. So if I can just continue a little bit more where we are with the campaigning, following on from that, well, interestingly, Public Health England, of course, is being disbanded, which has caused some problems, but the work is being picked up by NHS England and Improvements. And the All Party Parliamentary Group is part of an advisory panel that are feeding in to putting the Public Health England Review recommendations into practice. They made 41 recommendations. I mean, this is a significant number, a significant problem that they discovered. And so I and Mark, we are part of a withdrawal services working group who have been putting together some very practical and, we believe, workable solutions as to how people can be helped. And it's at 2 levels. It's getting proper recognition that prescribed drug dependence exists, that these drugs are dependence forming, and you can go into a terrible physical withdrawal when you stop taking them, particularly antidepressants. So that's the first thing, recognition, which requires an informed consent, which you touched upon earlier. Why don't people know about this? Well, it's because there's no informed consent in the doctor's surgery. So that's a very key part. And the second part is for those people who've already been caught in this terrible net, that there is support to help them to understand withdrawal, tapering, and this is a subject which Mark is very absolute expert in, tapering, and them to understand about protracted withdrawal. It's like long COVID. Once you stop taking the drug, it doesn't mean you stop your withdrawal. You can be ill for years afterwards.
I know that's a problem that I've heard about. People have been stuck on SSRIs and they want to be able to pay to like go in somewhere and be looked after and have, you know, actually.
There isn't anywhere.
Don't do it. Don't do it. I tried. It's about the worst thing you can do. It compounds everything.
But if nobody's recognising that there is this withdrawal syndrome, it doesn't even exist anyway. So, you know.
It is problematic, and again, as far as the campaigning is concerned, you know, that there are barriers to what we are trying to do. Of course, one of the major barriers is funding. There are lots of people scrabbling around looking for money out of the same pot, and that pot is severely depleted now by COVID. But also, despite the fact that there are a significant and growing number of us now who are working together to try and make this issue known, some of the major decision makers higher up in the NHS and in the political world, they still don't get it, because the expertise has come from the bottom up, from the patients up through researchers and some wonderful people like David. But the people at the very top, who are the final decision makers, they don't get the difference between prescribed drug dependence and street drug withdrawal, or they don't get it. And there's loads of money put into misuse. And they think that's enough.
It's often that we don't hear the voice of lived experience. I certainly know that. That was one of the reasons that I set up Sobriety Films, so that, you know, we could have a voice. I'm going to take some questions now.
Can I quickly chip in on 1 or 2 quick points here? Okay. One is that I think one of the things we need to recognize is that the people who are on the drugs complaining about the problems are really the experts. But there's a lot of doctors who, as Stevie has hinted, don't get it and things like that. And partly it's hard to know why they don't get it. It almost feels like they don't want to get it. Okay. Now, one of the things I would say to people listening in who are on these pills who are having problems is you're probably right and your doctor is probably wrong. That when it comes to what the effects of these drugs on you are, is you're the expert, whether your impression of what the effects of the drugs are on your eyesight or your ability to make love are the problems you're having months or years after you've halted the drugs. You're the expert, and you don't want to let anyone say to you that, well, you must be wrong, or there now, little girl, you know, I'm a doctor. When you've got 10 years medical training, come back and we can have a chat. That's not the way things are. You know, one of the key things for people is to hang on to the perception of what's happening and refuse to be browbeaten out of it. And one of the other things,
sorry to interrupt you, I'm having that battle right now with a GP.
one
of the moment.
One of the other key things is this, that a lot of people who are trying to withdraw feel awfully guilty. They'll blame themselves. It's because I tapered too quickly. Now, while tapering is awfully important, if you're going to have a serious withdrawal problem, whether you take 4 years to taper or not, you're going to have a serious withdrawal problem. And people shouldn't feel guilty if they end up in a pretty bad state, but unfortunately they do. They end up in a bad state and think it's my fault that things haven't gone the way they should have gone. And that's the thing that people need to hang on to, which is it's not your fault. The system knew about these problems 30 years ago and turned a blind eye to them.
Thanks, David. I've got a comment from the audience, and someone is saying, I work in mental health, and sadly, there's often dismissal from other clinicians about acknowledgement of withdrawal symptoms. I had one comment this week with someone saying that they hope that the film isn't going to add to the anti-drug movement. This was obviously frustrating to hear. I try to encourage open minds and inquiring, but sometimes I get too angry to eloquently and concisely respond to this text message. Any tips from the panel for effective reports or recommended quick, easy read resources I can direct those to with this kind of attitude?
Yeah, you're up against power, just like the person who's on the pills is up against a doctor who is reluctant to concede there could be a problem. So too, nursing staff and clinical psychologists and pharmacists are scared to speak up. You know, we've got a very serious problem here, and there's no easy fix to it. I wish there was a pill to treat the powerlessness people feel in these kind of situations.
Thank you, David. There's a question for Stevie. Oh, sorry, Mark.
Can I just go in there? Because I face this all the time. Look, I think it's very much, there's an analogy in my mind to climate change. You know, if you work in mental health, it's like working within the fossil fuel industry, and you're saying our products are causing unforeseen troubles, and no one wants to hear that message. No one wants to hear, you know, no doctor wants to hear you've been causing more harm than good. No pharmacist wants to hear that. No nurse wants to hear that. So there's instantly defenses up when that's heard. And also, everybody like me, I never heard about withdrawal in medical school or in psychiatry training. The first lecture I heard about withdrawal was one I gave. So if you know, I didn't mention this, but I've learned about this through my own personal experience coming off the drugs. If I had not experienced that, I would have found it very difficult to believe, to hear electric shocks and muscle movements and tremors. And, you know, that sounds to me, you know, I was taught these drugs are pretty safe. They're like paracetamol. It would have been very peculiar to me to hear all these weird things. I would have thought, well, patients are neurotic, you know, so they're probably mixing things up. So I would have been one of these doctors skeptical. You know, I've never heard this before from any of my professors who I've been, you know, taught to follow very closely. How can I take the report of people off the internet? So I'm not, I'm frustrated by my colleagues, but I understand where they're coming from. I have found people who change their mind are either people who have had first-hand experience, or someone in their families had experience, or I find people who have done a degree in ethics or philosophy and sort of think around the issue are able to see through the cracks. I also, I'm not sure if it's the right training, but I always think, essentially, when people when your average psychiatrist or average person working in mental health, who's not being paid by drug companies, of course, they're just, they're just honest NHS workers. They've got a choice of either believing the professors at the Maudsley, most of whom are paid a lot of money by drug companies, or believing patients. And I have seen when people have switched from taking their information from those professors versus people around them. So I think it's worth, keeping on talking about it, even if there is pushback. I think Simon Wesley was the guy who came up with pill shaming as a defense. And if you're talking negatively about drugs, it's pill shaming. That's a ridiculous framing. When you're talking about the adverse effects of drugs that people are using, that is just good public health. To not at all criticize drugs and to somehow frame that as being pill shaming or anti-psychiatry, is extremely unhelpful. Everyone should be about promoting use of drugs that cause less harm than good. And so, I would try not to be shut down by people who use those sort of slogans. In the same way they used to say people who talk about climate change must be communists. It's the same kind of one word dismissal, brand something, let's not think about it. So it's a very cheap tactic, not very useful.
That's very difficult if you go to your doctor and you're told, this is you're ill, you have depression, it's because of serotonin, and most, normal people would be that, they accept that and they wouldn't think to question that. But because I'm just going to add a comment from the audience here. From my own experience of taking antidepressants and switching from one medication to another, I've suffered negative withdrawal effects, all of which have made me struggle to a huge degree. On a general basis, do you believe withdrawal effects in psychiatric meds are researched enough? And if the research is limited, why do you think this is the case? And how do we counteract the devastating impacts of medication withdrawal?
Well, I have to chip in and say, when the pharmaceutical industry bring the next group of drugs on the market for people who are depressed, you will suddenly, and all doctors will hear about the problems with SSRIs and the dependence that they cause. And it will feature in the NICE guidelines, and the regulators will talk about it. The people who can really change things are the pharmaceutical industry, not the rest of us. There's no one on our side, not the regulator, not the NICE guidelines, not academia, not the government. So, it's a tricky situation.
I was talking to Mark the other day about ketamine, because that was hailed as the new nose spray, ketamine. And I don't think that's been made available in Europe. It just seems like they're kind of grabbing onto anything that they think can have some kind of effect. I've had ketamine infusions for my depressive illness, and they didn't work at all for me. I don't know what's the answer. How can we help people? If we can't give them medication that's helping them, how do we help them?
That presupposes that medication is required.
Sorry.
That presupposes that medication is the answer to their problem. And, we're framing all this around that someone needs to take a pill. And we need to claw back from that. We need to roll back from that and say, what does this person need to help them for? What has happened to them? Something bad has happened. What is it? Is it something from within the body? Is it a physical illness which has caused the mind to become upset? Or is it something external which has caused the mind and to be upset? And what is the best thing to help that person? And it's not necessarily a drug. And I think that that's the first place where dialogues have to go. We're starting to move into social prescribing, which I think is a very good thing. And people talk about, well, there isn't enough talking therapy, and there isn't. Most people, when they go to their doctor, irrespective of what problem that they go with, they're likely to be offered a prescription first and foremost. And I put myself forward as an example of that. The first time I went was insomnia, and then there was a patch where I was okay. And then I had, my mother died and I had 3 miscarriages. And I went back to the doctor, and this was in a period of 9 months. I went back to the doctor, and his answer as to why I was having trouble sleeping again and feeling anxious and a little upset was because I still had a chemical imbalance in my brain. And when I look back at that as a solution, I think it was abusive to say to a woman who'd been through what I'd been through. My hormones were all over the place. I was grieving at a double level, to be told I had a chemical imbalance. I didn't need a drug. I needed someone to talk to. And that is so much the case for so many people, particularly women.
Why are so many women prescribed antidepressants, Stevie?
Well, there was a classic example of, labeled, pathologized and dismissed with a prescription.
Is it like the hysteria, the old-fashioned hysteria? Is it that women aren't being understood when they're going in to see their doctor, and they're showing that they're stressed, they're bursting into tears, and the doctor's saying, take this?
We don't know how to sit with other people's grief and pain. As a culture, as a society, we just don't know how to do it. We're not trained to do it. Well, psychotherapists are, therapists are. Mentors are, coaches are, life coaches are. I retrained as one of those. Sitting with someone with their pain and helping them is what human beings need, and we don't do that.
I think when it comes to, sorry, in my experience of addiction, it's always been informed by trauma from childhood, and a lot of people I've met who suffer with addiction, it's trauma in childhood. So it goes right back down to when we're really small. So how do we, if that is like the beginning of someone developing, over emotionality or PTSD, or the reaction to what they're actually experiencing, which is real, did they grow up in a house where they're frightened to go home, or how do we, I just don't know how it gets turned into something that we can be given a pill for, maybe.
Well, that's a question for a psychiatrist. How has it got turned into something that you're given a pill for?
Right. Audience. Okay, so question here. Regarding informed consent, who would really sign it if they were truly informed about the horrific withdrawal that is possible? It's like signing up to heroin. For me, withdrawal from antidepressants was worse than heroin. I still have to try again to get off. Should we really be supporting informed consent?
Part of your problem with this one is that, as I say, all the information was there, but was not put on the table for people. And I think what the questioner said is right. If most of us were told about the risks of getting hooked, the fact that our ability to make love would be wiped out, that we may become agitated to the point where we actually became suicidal, a lot of us would have thought twice about it. And particularly if we were also told, now, for the most part, the nervous problems that you've come to me with are ones that are going to clear up naturally over the period of a few weeks or months anyway. And if these clear up without you taking a pill, in the longer run, you're going to be more resilient. If we were told that, we'd have said, well, it's good to know there are pills there, but I think I'll give it a miss for the moment. And that's the step that hasn't happened. Now, it hasn't happened not because people didn't know what the problems were. It's happened because they knew what the problems were likely to be and deliberately kept them off the radar for most of the doctors who are handing out these pills.
Yes, I'm sorry. So I agree with the questioner and what David said. I think informed consent is very important. And I think doctors have been mostly trained to not give informed consent in psychiatry. I definitely, in my training, I think one of the underlying messages was we sort of know these drugs are helpful for people, so we want to encourage them to take it. And so you present a rosy tinted view of the drugs. You focus on the positives. You say it'll make you feel better, and you say, oh, there's a few side effects, but they're not too troublesome. So you're sort of told to give a very unbalanced view of the drugs. And from my point of view, so on the other side of the desk as a patient, I'm very angry that I was not told the truth about these drugs. I started on them when I was 21. I was a quite unhappy young man, but I had imbibed, from medical school and from my doctor that this was a innocuous tablet. It would be a bit of a help. If I had known it was very hard to come off these drugs, it's taken me years to try to come off them. There's no way in hell I would have said yes to them. So I think it's a very old-fashioned paternalism that doctor knows best, and therefore they should present the information in a way that's attractive to the patient. And I think that doesn't make sense anymore. And I think we should be demanding from doctors that they do give a properly informed consent. And I think I've heard that what the question says before. I've heard that many times that it's harder to come off antidepressants than it is to come off heroin. I've heard that enough times now not to disbelieve it. So that's a significant issue.
One more thing to throw into the mix here is that the people tuning into this program, not just us here actually on the panel, know more about these drugs than a lot of the doctors who hand them out know. So this comes back to a point that I was making earlier. People should trust their own judgment about what's happening to them. And if they're not getting the right response from whoever it is they're seeing, they need to think about changing doctor, trying to find a doctor who listens to them.
This is an interesting question, something that's very relevant to me, creativity. And it's, do antidepressants and benzodiazepines harm other things like creativity? And what other things can they change about a person? Miranda, maybe you'd like to answer that. Did you feel changed when you were prescribed Klonopin?
Yes, is the short answer. I mean, I was a magazine editor, and I had a shock in my personal life, as I mentioned earlier, and I was put on them immediately. But I have to say, it's very hard to say what was at the beginning certainly a symptom of my insomnia and my shock, and what was a symptom of the drug. So I don't know is the honest answer. I mean, who knows? There's no blood test, there's no algorithm, but I just know that within, how long did I manage to, not sleeping at all for even 3 or 4 days sends you crazy, and this was weeks, and I was signed off sick within about 6 weeks. But creativity, I couldn't write my name, I couldn't speak whole sentences, I didn't have a phone. So talking about being creative and a writer didn't even come into the equation. I was struggling I didn't leave the house for 3 years. So the answer is sure. And it's unbelievable that I've got it back. But of course, I may still have it coming down the track when I've got these other things to come off. So then my question is, what do I do now? I've got, battle still to fight. I'm doing really well at the moment. Do I stay on 12 milligrams of pregabalin, Lyrica, because I can't come off it? I tried a month ago, as some people here might know. It was so terrible that I gave up. I've got a Z drug to come off. I've got a doctor who wants to halve my dose from 7.5 to 3.75. I'm saying no. We are fighting. I've pushed it down the road for 6 months to the next medication review, by which time I am planning to live in a different area, not because of that. So it's a constant, do you settle? Do you stop? Do you say, I'm going to stay on these forever? I think I've asked Mark Horowitz here before, why can we just not stay on them if it's so terrible? So it's a terrible Gordian knot of things.
Can I jump in and I'll give the answer to Miranda, and I'll give it to the audience. My experience answering the person's question is, when I was younger, I had a very good memory. Not to toot my horn, but I was a bright young guy. On these drugs, over time, became very tired, and I had real trouble remembering things and concentrating, to the point where I'd actually topped my medical school at the end of the degree. But over time, I became so impaired in my ability to think. I first of all dropped down to part-time work, and then I found myself walking around the hospital carrying a piece of paper and a pen, and anything that anybody would say to me, I'd write down, because if I didn't write it down, it was completely gone. If people asked me about a patient, I didn't have a piece of paper in front of me. I couldn't remember their name, who was being talked about. It became so embarrassing that I was on the point of considering medically retiring from work and applying for disability. And it was at that point that I thought, look, I'm on 4 drugs now, 4 psychiatric drugs. You know, is this a part of the problem? And it's at that point, at that very low bleak point in my life, that I decided to come off them. And the main thing that's happened, it's been now 2.5 years. I'm still on 3 drugs, but at much lower doses. The main thing that's happened is that I can think again. So I've had, in the last 2 years, I've been more productive than I was for the 10 years before that while I was on drugs. So although it has been excruciating, I would say, to come off these drugs, I've had some extremely unpleasant periods. In my mind, there's nothing that I want to do more than come off these drugs, because the pleasure of getting back the ability to think straight and to work makes me feel like I've been given a second chance at life. So I will walk over broken glass to get off these drugs. You know, that may not be true for everybody. I understand sometimes it's very difficult and you might decide it's too much, and I wouldn't ever push anybody, but from my point of view, you know, this has been a second chance at life. So I'm incredibly grateful that I worked out that it was the drugs, and also, of course, very angry that it's happened to me for so many years.
Thank you for sharing that, Mark. Okay, this is going to be the last question because we're going to have to wrap up soon. And that is, where do patients find trustworthy information about coming off of psychiatric drugs, and where do family members of those coming off go for support and education? Because it is the people around the person who are suffering as well, isn't it? It's like waves. So anybody got any ideas?
Well, I think it comes back to people need to trust themselves. And one of the problems they may have, when you've hinted at, it isn't just the person, it's also the people they live with. One of the problems can be the people you live with are inclined to believe you're a doctor and not you. It really does come back to people figuring that what they're experiencing is what they're experiencing, and sticking to it and finding a friend or a doctor or whoever who buys into that, who recognizes that this person I know is a sensible person, and if they're saying what they're saying, that they're probably right, and I need to help them build on this. What the answers may be, you know, where to go when you begin building may not be obvious. It may be a very delicate path where you have to just crawl along bit by bit. But yeah, I think the person on the pills knows what they're going through and needs to be supported.
I totally agree. I think it's so punitive, so punishing if you're already suffering from something like depression or anxiety to have to, you know, have people not believe you that you're feeling these things. You know, it's enough that you've got depression and anxiety.
And whoever mentioned the guilt thing is absolutely right.
Mm-hmm.
Guilty.
Yeah.
Somehow.
Yeah.
Like it's
Feel
all
failure. Sorry.
No, yeah, it's
failure, total failure, because couldn't get off them.
Mm-hmm.
So guys, we're going to...
Can I just put in one practical point? Sorry. So yes. Just for people who are asking where is useful information, it's not perfect, but the Royal College of Psychiatrists guide on how to stop antidepressants, I've just put it into the chat. You know, it is something, it's 7 or 8 pages. It's not brilliant. It's not comprehensive, but you can hand it to a GP. It's got the Royal College of Psychiatrists branding on it. It says you've got to come off it slowly. It says for some of the drugs, it'll take years. It says people can have real problems. I would certainly bring that in to a GP and to give to a family, because it's a recognition by authorities that this is a serious issue. My starting point.
sorry, Mark, I'm wondering how many people are affected by this in the UK. I mean, it's impossible to know, isn't it? Is it possible to know? How would we know, that people were suffering adverse effects from SSRIs?
I think most of the people who are on these drugs for any period of time are going to find it hard to come off them. And they will end up often saying these drugs are great, wonderful, and marvelous, because when they try to come off them and have problems and then take a pill again, they think this pill has saved their lives, when in actual fact, what it's doing is treating withdrawal.
Someone who's just said that recently in the press is Frankie Bridge from the Saturdays, and she was saying that she'd gone away and forgotten to take antidepressants with her and gone into withdrawal after a day and was getting the head zaps, and she said she thought that she'd be on them for the rest of her life.
So the Frankie Bridge articles are a sort of a head slap moment, because she said, when I stop these drugs, I get brain zaps. So everybody out there, do not stop your drugs, because your illness comes back. So she's making a terrible error there, thinking that brain zaps are a part of her underlying condition, depression, and mistaking, exactly as David said, that the drug stopping withdrawal means the drug is helping the underlying condition. It's a terrible error. It's being propagated everywhere. It fits right into drug companies' plans. So I think it's worth talking about withdrawal so people understand what's happening to them, rather than getting caught in that trap. And so the answer to your question is, millions of people are at risk of this. There are 7.3 million people every year on antidepressants in England. Estimates are that about half of people will have trouble coming off. I think that's actually a low estimate, and that means that there are millions of people who are at risk of this. So as David says, it's a huge public health problem. It is definitely a ticking time bomb.
Thank you, Mark. So we're at the end now, so I just want to allow you panelists to just express some last thoughts about the whole evening, the film, and how do you feel? You'll have to be quick because we've only got about 3 minutes left. So Stevie, do you want to start?
Well, what can one say, really? Watching the film always. This is the third time I've seen it, and I had to watch it yesterday. I couldn't have watched it beforehand because it just upsets me. No, upsets. Sorry, that doesn't sound right. I find it distressing because of the stories and the way people are constantly treated, and veterans particularly. I mean, that's a whole additional class of people who have probably been damaged by the drugs that they were given before they went away. Never mind then being treated the way they are once they come home. It's just appalling.
Thanks. And David, do you have any thoughts to sum up with?
Yeah, sure. I think this is a real crisis, and particularly for people who are young. We've got an increasing number of teenagers being put on these drugs. Antidepressants are the second most commonly used drugs by teenage girls. And actually, there's been 30 clinical trials done in these drugs for teenagers, and every single one of them's negative. So this should not be happening. This is a wake-up call for all of us. And teenage girls, I think, need to, women generally from the age of 15 up need to realize this is a feminist issue, and they need to pick it up.
Thanks, David. Miranda?
Well, I'm going to say something a bit different. I'm going to say that there really is hope. I'm going to say that it's terrible what's going on, and it's not your fault, and it's not a question of weakness or strength or morals or failure. But I am not off all my drugs, but I am off a significant number of them. I am doing really well. I've written a book in the last year. I have got a new boyfriend. I have got a new career. I've got my relationships with my children back. Now, just, today things are great. They may not be in 2 weeks, but I've had a really great 2 years, actually. So it can get better.
Thanks, Miranda. Mark, finally, any comments?
I'll give a quick one. I think it'll take a lot of time to re-educate people that the drugs are not benign in the way that we've been taught for many years. And there are people who are writing newspaper articles and writing academic articles and running campaigns. I think everybody doing something will have an effect. So I've got to say I'm a little bit hopeful too, because I think, again, the analogy to climate change, one of the things on the side of the climate change campaigners was truth. That was a strong. If it had been a communist plot, it wouldn't have come out, but it was based on truth. There's clearly evidence that everything we're talking about here is real. I think, you know, truth will out in the end. So I think people should try, and I think that involves talking one-on-one to family doctors. I can hear that Miranda's having a terrible time, but I think it's worth. I think when a GP has 5 patients come to them at different times and say the same thing, at some point the barriers have to come down. So I would say, although it's probably depressing and frustrating work, to keep on trying to talk about it and to be a bit emboldened and to let people know it's, you know, it's not you, it's not your fault, it's not something wrong with you, it's a very widespread issue and people need to know about it. And I think, you know, in a few years things will be very different. As David says, I think it may be the next wave of drugs that come in, but hopefully people can also spot the pattern at some point. I don't know.
And Mark, you're training to be a psychiatrist, so there must be hope.
If they let me.
We'll all come and see you. You're going to have a very long queue outside your office.
Okay, they're going to let me through the gates first. I'm not sure about that.
Okay, thank you. I just want to say thanks so much to everybody that attended tonight. Thank you so much to the audience and to the panelists. Great you've been here, thank you. I want to also thank the Genesis Cinema for their commitment to diverse programming, my team, Moira, Keziah and Adam, and finally the Medicating Normal team, Angie. It's been amazing, thank you so much. Good night, thank you very much.
Night.